Hello, everyone. Thank you so much, Marion, for your really interesting presentation. And I'm very pleased to have a big picture global perspective to frame some of what I'm going to be discussing today. So I'm very, very pleased to be here today, and I'd like to thank the conference organizers for inviting me and the CIHR, who I think is a co-sponsor of this particular panel, and who is very generously supporting the research I'm discussing today. I have three goals for today, and that is to highlight the ways in which social inequities can be embodied in particular patient populations, and to provide examples of the face of inequities in a community sample. And I hope that this sets the stage to discuss how contextualized data on patient populations can help to inform primary health care service delivery to optimize their responsiveness to particular inequities. I'll start by emphasizing, as you all know, that the primary healthcare sector is increasingly relevant as a site for population health interventions, particularly in relation to vulnerable populations where we expect that the greatest gains can be achieved. And we know from the mounting bodies of evidence that enhancing primary healthcare services for disadvantaged populations has the potential to result in improved health outcomes for the population as a whole. However, less is known about how to enhance capacity to promote health equity in the midst of busy and often overflowing primary healthcare settings, and the feasibility of doing so at the organizational level, and the structures, policies, and processes that are required to support equity-oriented services. And the challenge at the service delivery level is how to tailor service and delivery to address the negative health effects of increasing socioeconomic inequities, systemic and interpersonal discrimination, and the shrinking social safety net that is characteristic of today's neoliberal political landscape. Like Marion, we are very intentional about our framing of the use of the term health equity as a concept that's distinct from health inequalities. And we're also framing health inequities in Canada as a manifestation of structural violence drawing on farmers' work. Structural violence is increasingly seen in public health and population health as a major determinant of the distribution and the outcome of health inequities. Social inequities are, of course, at the heart of structural violence, and of moral concern is how these inequities are flourishing in the face of great affluence in Canada. And particularly, this is visible in the city of Vancouver, which I'm showing you some pictures of. So I'd like to draw on some examples from the health equity programmatic study that we're now in the midst of conducting. The long title is here, and we've affectionately renamed it the EQUIP study. This is a research program that's built on a strong foundation of partnerships between university researchers and knowledge users in the federal and provincial health sector. Beth Jackson, for example, is a knowledge user that is based at the Public Health Agency of Canada. And in a nutshell, the purpose of EQUIP is to test the effectiveness of a multi-component intervention to promote health equity for marginalized populations at 4 primary health care agencies that are serving very diverse populations. Secondly, we are aiming to identify and operationalize measures of equity-sensitive primary health care to capture the processes and the impact of services, and to analyze the policy and funding context that can support the uptake of equity-oriented services. And to do this, we're partnered with 4 primary health care clinics. 2 are in BC and 2 are in Ontario, as marked by these red stars. These primary healthcare clinics are very diverse. And this contextual diversity is really important when we interpret the data from our study. For example, the clinic's geographical catchment areas, their unique patient populations, and the interdisciplinary mix of staff are very important contextual factors that shape the implementation of the intervention we are working with, and importantly, our interpretation of the data that's coming out of EQUIP. For example, at one of these clinics, 75% of the patient population identifies as Aboriginal and is located in a core urban area of a major Canadian city. Another serves primarily young families on low incomes that are led by single women most often. And another is located in a rural farming community in southern Ontario. However, what is common to these clinics is their interest in making services as accessible as possible to people who typically face a great deal of difficulty accessing services. And very briefly, this is a glimpse into our overall research design, which is using a mixed methods case study design with the primary healthcare clinics as the unit of analysis. And we've sampled 568 patients from across the 4 clinics who we are following as a cohort for 4 data points over 2.5 years, and we've collected 2 waves of data to date. We're very pleased with our retention rate so far, given the social context of people's lives, and given that many of the people would be often lost to follow-up or are not people who are typically included in population-level samples. And these are the various components of the patient interview guide that we're using. We're assessing healthcare utilization and experiences, people's confidence asking and seeking out services, demographics including financial strain and their housing situation, health status and quality of life. And we're particularly interested in EQUIP, in the intersecting issues of chronic pain, depression, and the health effects of trauma and violence, which are not typically considered in health indicators. What's been fascinating is observing and tracking how the primary healthcare sites are using components of these data to tailor their services and policies to their unique contexts. And I'd like to show you a few examples. Just in terms of some of the socio-demographic features of the EQUIP sample, our sample is for the most part quite middle-aged. There are typically more women in the EQUIP sample, with the exception of one of the sites, and this reflects the gender proportions of the total patient populations at these clinics. We used a measure of financial strain, which showed 70% of people reporting that it was somewhat or very difficult to live on their current household income. And here we're comparing financial strain to the population percentage in Canada who are considered to be on low income after taxes. You see financial strain varied by site, with the highest financial strain being reported by people living in the urban core areas where 2 of the clinics are located. Many of the patients in the EQUIP sample are on social assistance or disability payments, with somewhat lower rates in the rural farming area in southern Ontario. This compares with social assistance rates that we have seen in the literature, which for Canada are estimated to be approximately between 6% and 7% of the population in 2012. And this helps to explain why shelter use in the EQUIP sample, its shelter use at least one time in the past year, was so high in 2 of the sites compared to rates reported for Canada, with the exception of the sample residing in the rural area, where housing stability is much stronger. Rates of depression in the EQUIP sample were very high, with almost 42% meeting the DSM-4 diagnostic criteria for major depressive episode, and this 42% compares with rates of major depression in the CCHS sample, which is estimated to be 4.8%. It was perhaps the symptoms of trauma, and you'll see coming up chronic pain, that were perhaps most concerning to us and to our clinical partners. The first red bar is showing the percentage of patients who meet the DSM diagnostic criteria for PTSD, post-traumatic stress disorder. And the second red bar is showing the percentage of people who scored above a certain cutoff, indicating severe symptoms of trauma. So symptoms of trauma are very, very high in this community sample. And the issue of trauma is further illuminated when we look at scores by primary healthcare site, with the lowest scores in the rural farming area and the highest scores in the site where 75% of the patient population identified as Aboriginal, pointing to perhaps the significance of intergenerational and historical trauma and the ongoing traumas of everyday discrimination and racialization in Canada. This compares to rates of PTSD that are estimated to be between 8 and 10% in the general population. In terms of chronic pain, we were very concerned about the high rates of chronic pain among the equipped sample, which we measured in relation to pain intensity and the impact on one's abilities. Pain grade 4 is a very debilitating level of pain, and you can see the proportion of people reporting that. In terms of the chronic pain grade by site, you can see that the blue bars are indicating a very high degree of chronic pain, which ran as high as 38.6% of the patient population in one of the sites. These rates of chronic pain compare to an estimated 17% of chronic pain in the total Canadian population, which is reported as a dichotomous variable, yes or no. And finally, I'll show you a bit about self-reported oral health. Patients in the equipped sample reported significantly higher rates of poor or fair oral health compared to the Canadian population. And our crosstabs are showing that poor oral health are very strongly correlated with overall health status, with people's chronic pain levels, and with their depression levels. Again, by contextualizing this data by site, we can see that Site D, which has the lowest overall SES and the least access to dental care, has the poorest oral health, with 65% of the patients reporting poor or fair oral health. As I mentioned, aspects of these data are being considered by the clinical sites in tailoring the unique application of the EQUIP intervention in their local contexts. And I'll wrap up by showing and perhaps foreshadowing some of the measurement work that we're currently engaged in, one element of which is the development and testing of a theoretically grounded measure of equity-oriented healthcare. And this builds on our previous theoretical work, which identified the key dimensions of equity-oriented primary healthcare services. And we've now developed and refined a patient self-report tool and are now testing it with data collected from the EQUIP sample in the various EQUIP sites. And these are the 5 domains for which we've developed subscales for this. This measure is looking promising, and we think it will address a critical gap in health services research, and so the work continues. And I will close by saying that we in the primary healthcare sector are indeed finding ourselves to be delivering services in very difficult times. This highlights the need for innovative approaches to measuring, contextualizing, and redressing the intersecting manifestations of health and social inequities. So it's encouraging to know that researchers and theoreticians like yourselves are doing this kind of work. And with that, I'll close, and I'd love to hear your comments and questions.